Okay, so we're now going for communication with patients. Communication with patients is our topic for today. So this is the patient, and the other one is the one giving the communication. That can be the nurse or any healthcare professionals. So the learning outcome for today is for you to be able to discuss the therapeutic listening skills and discuss purposive communication with patients and explain the use of different types of questions for patients. Now, the introduction is for you to know that good communication is between the nurse and the patient for a successful outcome of individual nursing care of each patient, and can only be achieved when nurses understand and help patient demonstrate the kind sincerity and politeness and devote time for patient to communicate and based on nurses' physical abilities as well as educational uh, experiences. So this is the listening skill. As you can see, the nurse or this health practitioner is trying to listen to all the patients that they to the two patients that she's trying to communicate with. Now, the listening is important in communication. Why? Because it is responsible in nursing practice and requires concentration of attention and mobilization of all senses for the perception of verbal and nonverbal messages emitted by each patient. So by listening, nurses assess the situation and problems of the patient. They enhance his or her self-esteem and integrate both the nursing diagnosis and the process of care at all levels. So this is the listening skills definition. They are trying to do the receiving from the far end, that's receiving, then focusing, and then deciphering, and then accepting, and then storing. So when you try to listen, you try to receive first. Receive is very shallow. It means hearing or receiving the sounds. And focusing, it means paying attention to what you have heard, because sometimes we are like receive here but exit on the other side. So when you try to focus, that means you're paying attention to what you have heard. Deciphering means decoding, because sometimes when we listen, there are some other codes that we don't know how to interpret. Like, for example, we listen to the heart rate. It's not just the rate but also the rhythm, and we're trying to decipher, especially the blood pressure. We're trying to know what we heard on the systolic and the diastolic. We're trying to decode it, whether it has abnormality or it has something that is abnormal on what we have heard as a message. We're trying to decode it, deciphering, decoding. Or it can be as simple as the way that the patient talks to us, whether they are confused, alert, or mumbling sounds. Psychiatric patients in the mental institutions, they have their own confabulation of words, and they have their own flight of ideas. So you're trying to decipher and decode whether the ideas are flying, whether they are mumbling, whether they are confabulating the words that they have. And sometimes we have this onomatopoeia and the clinging clang, the clang association of words, and those are the decoding things that we like to try to listen. Accepting means interpreting the message as intended by the speaker. For example, you try to heard something, you interpret what you have heard because you have already decoded it. Now that you have decoded it, you're trying to accept the interpretation. Storing means remembering. That means when you listen, you remember what the client has said. When they say that they are Islam, they don't eat these haram foods. So you don't forget, because you have accepted, you have deciphered, you have accepted. Now you store the information, you don't forget. Example, the Buddhist tells you, I'm vegetarian, so don't give them food that have meat, and you have to listen, you have to store it, and you have to remember it. You cannot forget. So when you try to store it again to your own personal storage memory bank, that means you have listened carefully. Okay, so listening, it requires eye contact body gesture, and show that you're listening, and avoid distractions for your listening skills. Give feedback, ask questions to clarify certain codes that you don't understand, or look at other options to clarify codes that you have listened to. For example, heart rate and rhythm. You heard the rhythm, you heard the rate, you heard the sound, but you don't know how to decode it. You give feedback or opinions to other experts so that they can give you the analysis or the interpretation of what you've heard. And listening allows you to plan and to have relationship over the one that you have listened to develop and to be the part of something, to create, to think, and much more. So, face the patient and maintain eye contact. You know, when you're trying to maintain, what if the patient is blind? At least you have to face them, even though they're blind. They cannot maintain eye contact, but you're facing them, talking to them while you scan the room, study a computer screen, or look at a phone signal that you're not fully present to, and pay attention and listen fully. Nurses cannot be blind. Patients can be blind, but nurses cannot. So you still have an eye, and you should make eye contact and be attentive and be relaxed. You know, similar to the first point, being attentive is key. But for patients who may feel scared or anxious, keeping a relaxed demeanor will give them comfort. So keep an open mind and listen without judging to the family or to the patient, and listen without jumping to conclusions. Although you might have heard this before, it is new to the patient or family member, and additionally trying to avoid a sentence grabber or talk over the patient or family. That means you don't assume that they have heard it before, and you don't grab sentences, like you don't finish it and assuming that they have heard this and they have already understand, and talk over to the family or patients. That means you don't butt in while they're trying to have a question, because you need to listen first. Wait for the speaker to pause to ask clarifying questions. You can say, wait a second, can you back up if you don't really understand what you're trying to say? I didn't understand what you just said, so ask questions to ensure understanding so you can respond appropriately. So, give the speaker a regular feedback. You know, when you give a regular feedback, like for example, you say you are okay. By the tone of your voice, you seem upset. So paraphrase what the patient has said to make sure they know you have heard them, and you can say, let's see if I got this right. So there will be things that you can make sure of that they got right. Pay attention to what is not said. Look at the nonverbal cues that might give you hints about what the patient or families feeling that they could not say it. We can see that the patient's face look upset or sad, but they don't want to say it. So pay attention to what is not being said by looking at their nonverbal cues. So practicing your listening skills will help you cultivate the tool on listening to understand and convey to patients and others that are really listening, and help them at the center of their own care. So, the purpose of communication is the nurse-client communication. This is one of the purpose of communication. As you can see, this is the nurse and this is the client, and they develop trust. So this is like purposely the nurse is talking to the client, and purposively they develop trust, gather information regarding clients' well-being, and provide information regarding general health and specific health problems. Guide the client so as to recover, because this is what you call a purposive communication of a nurse-client communication. So, nurse-family communication is also purposive because they give information with a purpose regarding the patient's health status to his, her, or her loved ones, and they guide relatives so that they can care for a patient in the home and provide information to relatives regarding specific health problems so they can assist in patients' lifestyle modification. So, the nurse health team communication, because it doesn't have to be only you and the client. It can be in a communication team, it can be in a team way where they enable continuity of care, share health needs of the patient, and provide information regarding specific health problems, and discuss together what best can be done for the patient, for the client. Now, there are uses of different types of questions, because you don't just ask questions per se, like open-ended and close-ended questions. Those are the basic type of questionings, but there are the usage of different questions. An open-ended questions um, should have this exploration to allow the patient to talk about his or her views about the subject. In this way, what the patient sees as important and what his her intellectual capacity is, and how well oriented she or he is becoming, will be clearer. And this encourages the patient not to say yes or no, but for example, how did you experience the pain? Because if when you're talking to patient, we usually ask for pain because pain is subjective. And aside from that, we can see nonverbal cues, we can see nonverbal communications, we can see signs and symptoms. But for pain, measuring pain is more on asking them questions. So how did you experience pain? Not just asking them, is it painful or is it not painful? You say you felt dizzy, and then try to let them explore more. Give them an open-ended question. Tell me more about that. You can explore further. So a close-ended question are questions that require only single word as an answer when specific information is needed. If this type of question is used often, the patient are less inclined to give the information and may be interpreted as an interrogation. Like, do you feel any pain in your arm? Close-ended question means it's closed. The only answer is yes or no. I want to know if it's yes or if it's no. Because sometimes vital signs will be manifested on specific parts, especially referred pain, and therefore answerable by yes or no is more important than exploration. And also sometimes the patient can lie to you with regards to pain. Something like they call it minta muji, when they seek attention from the nurse because it's boring in the hospital. They want to seek attention, they want to tell you about the pain that they're experiencing, but it's not really a referred pain. So you can ask the close-ended questions. Why questions are questions that has demand that the patient explains behavior, feelings or thoughts, and that she or he often does not understand himself or herself, because these are mentalities of the patient that they do not understand themselves that well. These questions are often asked early in conversations when the nurse cannot even be certain that the patient wants to explain himself or herself to the nurse. So the question is, why are you upset? This is one of the basic questions. Why are you upset? Patients are sometimes embarrassed to ask questions, and in some cultures, differences to authorities stifles questions, because sometimes your authority figure should not be receiving questions from you. Sometimes you only have to say yes and no to authority figures. Those are the cultures. And some cultures are creating shame-free environment that encourages patients to ask questions, and is also an important way to engage patients as active partners in their healthcare, and is crucial in promoting patient safety and good health outcomes. So, this is the conclusion. Listening is very important to patient care, because listening on patient communication is receiving information and being empathetic to them. So, let me give you the next PowerPoint presentation. Okay. All right, this is communication with patients, and communication across lifespan is very important in communication with patients. So the learning outcome is for you to discuss communication across the lifespan and define assessment tools, explain giving information, education of patient, and family. So, language and communication skills change throughout a person's lifespan. As a result, patients of different ages respond to and communicate about their health in different ways. To learn about human growth and development is one of the communication across the lifespan. And exploring the different theories of human development and behavior, as described by Jean Piaget, Eric Erikson, Sigmund Freud, and B.F. Skinner, learn how these development theories affect how we work as healthcare professionals and how we can communicate effectively with patients from all age groups. Now, the Eric Erikson theory is more into the psychosocialization theory. You know, when we socialize in a psychological way, we try to communicate. And people move through 8 stages as they progress from birth to death. That's the theoretical framework of Eric Erikson. Now, the trust versus mistrust is the first stage from Eric Erikson's theory, saying that the first stage occurs during infancy. This is the trust versus mistrust. When you were born, you try to communicate things. You know, when you cry, it's a communication. And sometimes your mother tries to decode the way you cry. Our neonatal nurse tries to decode a patient's, or a baby is a client. An infant can be a client. And these infants have their way of communication skills. And this is what Sigmund Freud is trying to say. Not all people who can talk are the ones who can communicate. Those who cannot talk can also communicate. Like the infant, during the stage of trust versus mistrust, infants communicate. They try to tell us what they feel, and we have to listen. And we have to decipher and decode what they're trying to send as a message. And these infants have the ability to end up mistrusting when they grow up. It's an effect of the timeline from which they started their communication process, and nobody listened to them. So in the long run, they become mistrusting. They don't trust people because nobody wants to communicate and to give them the need that they need as a basic warmth, food, and comfort, which develop their feelings as a safe place. They begin to lose the safety of that environment, and when they reaches the age of 18 months, 3 to 4 years old, they have this tendency to lose their trust by being shameful and doubtful because they don't have the safety of their environment where they can have a communication that's safe. Autonomy means the ability to do things on your own. From the age of 18 to 3 to 4 years old, toddlers seeks a degree of autonomy. They want independence, independent to kanching, independent to berak. You know, when they try to poo-poo and they try to pee-pee on their own, they begin to become ashamed of what they have because they don't trust the environment of where they are. Since they were young, they have never trusted the environment where they are because they're trying to send an information, they're trying to send a message and nobody wants to listen. Now, at the age of 3 to 4 years old, they lose their autonomy. They become ashamed and they become doubtful. Some toddlers are not are becoming introverts. Some toddlers are becoming extroverts through this stage, and they will develop a sense of autonomy as well as self-control and self-esteem when their trust versus mistrust stage have already been developed from the beginning. And across the lifespan, they begin to grow older. This is the next stage of Eric Erikson that says initiative versus guilt. During the preschools, they have the initiative to go outside the real world or go with their friends and have the initiative to do things on their own, or they're guilty of making mistakes because they have shame and doubt. They become guilty of doing things that are not correct. You know, everything to them is wrong when they were toddlers. Bad, this is no, this is wrong. That's why during toddlers we don't say negative things on children because they become guilty at the age of after 8 years old or after 9 years old. The initiative will be lost. And this is the exploration stage where they ask questions how and why, and we need to listen to these questions, and we need to have this kind of explanation to them, like, why am I a girl? How was I born? Mommy, why do you marry a guy and then you have a baby. So how did you form the baby on your womb? These are the questions that they will ask at the age of 9, 10, 11, and up to 12. They have this feeling of exploring themselves, and we need to give them the chance to explore it further. Otherwise, they'll feel guilty of doing things. They feel like they will hurt girls because their mother and father are divorced. They will hurt the feelings of all these people. They become to feel guilty of the things that they do not want to have as a wrong interpretation of what they're trying to explore. Then, at the age of puberty, when they go to the school, puberty starts at 12 for menstruation. Some female got menstruations at the age of 10. Some female got menstruations at the age of 12 or 13. It depends on your physiologic capacity. So, school age is the age of the start of puberty. So they begin to focus on the end results of the task and seek recognition for their accomplishments. They become industrious, or because of the guilt feeling, they become inferior. They have inferiority complex. They are ashamed of themselves because during the time that they were young, they were not given the chance to explore. And to seek recognition for their accomplishments, a child may paint a picture to receive praise from a parent. They become industrious. They become more of industry versus inferiority. Avoiding a sense of inferiority is during this stage. And identity versus role confusion when they begin to start at their early adolescent stage. Who am I? They begin to ask questions because during the time that they were inferior, they were never given the chance to become industrious. They are confused already who they are, if they are confused. So make sure the communication process is starting from the age of trust versus mistrust, so that they will not have a confusion on their role or their identity at the age of 18 to 20. And during this stage of development, the key is to achieve ego identity while avoiding role confusion. So the next stage is the intimacy versus isolation. This stage's development occurs during young adulthood or between the ages of 18 to 30 years old. However, the age at which this stage occurs varies dramatically from person to person. Their communication is varying from person to person. And during this stage, individuals must achieve some degree of intimacy to avoid isolation. Some people don't want to get married, some people want to be alone, and some people want to have intimate relationship with people. And this is where they can communicate because they have the connection with other people. They begin to take the role of connecting with others. Then they want to be intimate because they know that they are not inferior. They know that they have their industry. They are not confused with their identity, and they have their own identity, and they can connect with others. That's the time they become intimate. And generativity versus stagnation is the middle age. When they have the mid-20s and late 50s. This is the generativity versus stagnation. It's either they can generate or they can stagnate. This is a concern. A generativity is a concern for the next generation and future generation. They began to pass on what they have learned as an experience. They communicate things. That's why old people wants to talk, always wants to talk what their past experiences are, and you're there to listen to them because they want to give you advices, and they can generate new communication process for the future generations. While stagnation is being self-absorbed and obsessed with their own needs, or they are stagnant on their own things because they cannot generate. So the ego integrity versus despair is in the late adulthood, somewhere in the 60s of age, and individuals must develop this ego integrity because it's the ability to reflect on the course of life, including the choice you have made, and to concern through the course of your life. Okay, so this is the figure of Erik Erikson's stages of psychosocial development. It's more on socialization. So this is the difference between Piaget Freud, Erikson, and Skinner. Jean Piaget is a cognitive development. Freud is psychoanalytical, which is more on the psychosexual theory. And Erik Erikson is psychosocial, while Skinner is on behavioral. Communication with clients, giving information and education to family. When you communicate to family of different groups and age, we need to change the technique to match the age group of the patient and to help increase the effectiveness of communication with all patients. So always speak directly and give patient your full attention, and always speak clearly. Make sure your message are clearly stated and easy to understand. Always check for the patient's understanding. Return demonstrate. If you don't want to return demonstrate, return the discussion back and ask the patient if he or she has any questions, and make sure the patient understands what is being said to them. Always pay attention to the non-verbal messages and the patient is sending you. Ask for clarification if you're unsure what the patient is trying to say, or ask patients to repeat instructions or to return demonstrate what you have taught them. For example, wound dressing or insulin injection. You know, when you try to communicate insulin injection, you don't assume that they have learned it. You have to let them return demonstrate on themselves. They might inject it to someplace else that is wrong, or the degree of injection of insulin, because sometimes mothers are the ones injecting the insulin to their children, especially for type 1 diabetes mellitus. For those who have inborn diabetes, it's type 1. The mother is the one injecting. So you have to make the mother return demonstrate what you have communicated to them. Repeat the instructions. Or if it's tracheostomy, patient can go home with tracheostomy. They can have their parents or have their loved ones or their neighbors do their suctioning on them. So you have to return demonstrate, because it can lead to trauma on the trachea. Okay, so communication with children, this is a very difficult communication because you need words, tones, and body languages that are more important, and talk at eye level, speak gently. Move slowly and visibly, announce your touch, rephrase often, allow crying, and use toys when appropriate when communication with children. Communicating with adolescents is respecting their privacy and giving them choices. Remember that respecting the confidentiality must always be emphasized and reiterated. Tell them that nothing will come out, nothing will leak out. You can trust me, and don't worry about anything, because we will not tell anybody of your private information. Communicating with adults, assess how much information the adult patients wants to know, and make sure your message are clear, and make sure the adult patient can follow your treatment plans. And communicating with older adults is much difficult, because you need to respect their dignity and involve them in decision making. They are older adults. Look for verbal and nonverbal cues and provide reassurance and empathy when appropriate. So this is the communication with clients.